Good morning, Andrew. How you going? That's crispy clear.
Ain't that just perfect? Just like the sky today. Just like
Great
our
to see
mission
you
in
again.
life. Yeah.
Great to.
Hey, you had a good one. You had a good one with Brogan last week.
Yeah, it's been super busy 2 weeks since our last chat 2 weeks ago. We've had a really long, I think it was getting close to 2 hour podcast with Brogan,
That's huge.
the squat doctor.
Yeah, he's
Uh,
great. He's a wonderful guy.
that guy's a champion. You know, likely as passionate as we are
Oh,
about the topic.
definitely. He's a little bit new, and he gets triggered a lot more than say I do for sure. Because I'm really sort of saying I know what it's like when you get in that position, and
Yeah,
you see things that offend you. But if
yeah,
you end up chasing all the offences, you're going to be chasing your own tail. You got to actually lead. We got to be
yeah.
leaders and not reactive, not
We
counterpunching all the time.
we've all made that mistake of getting a little bit um, emotionally attached to the argument, and it
Mm,
needs to be very objective and scientific in our approach if we're going to make impact.
absolutely. We have to be presenting, well, not even the argument, just presenting facts and science.
Yeah,
So when it comes to people who have got problems with that, they're always going to have problems with things. So, that's their problem, not ours.
yeah. Well, we're recording now,
We're live. Yep.
and what should I think we were going to talk a little bit about myths and misinformation today.
And management, because we're really going
Yeah,
to talk about the failures of back pain management,
yep,
because I
yep,
think that's a really good lever for us to work on today.
yeah. Just
Because
on
we'll
just
talk about it from both ends.
that last point about Brogan, there's one thing that he knows how to do very well, and that's lift.
He lifts wonderfully, doesn't he? Huh?
And that's
he's
lift very heavy things.
Yeah, he's
Which
sure built to lift, and he's taken advantage of that, and he's applied the science, and he's got the results.
yeah, I think that should be our sort of subheading to our brand of the college is, you know, learn how to lift, and you'll understand everything we're talking about.
There it is. I think I put that up on my little Instagram today. Yep,
Yep,
for the people who
um,
tell us how to lift, who don't lift.
exactly right. So I really enjoyed having a listen to your. I think it must have been a couple of years ago. Your podcast with Greg Lehman. That was very enlightening.
That was very
Um,
enlightening, wasn't it? Yes, set up by
yeah,
a pain scientist moderator who didn't stick to the questions that he had sent me.
yeah.
That was quite amusing.
I hadn't heard of that moderator. I hadn't heard of that moderator. But I'd heard of Greg Lehman, primarily because one of his sort of slogans is reconciling biomechanics
Yeah,
on his website. And then
slag you off biomechanics.
it was quite astounding to then hear a lot of his comments about how biomechanics weren't that relevant. And I think he's done a lengthy podcast or lecture at the San Diego Pain Conference, and
It
I
makes
think
sense.
the title of the lecture was um, "When do biomechanics matter?" or "When do biomechanics not matter?" And I thought, well, that's strange because biomechanics always matter. Um, so,
Always.
and I listened to that lecture, and it was really quite nauseating, to be honest. Everything
It
that he
would
was
be.
saying was just muddying the waters and just confusing the bejesus out of the community and also the audience who were in the rehabilitation industry. Um,
Well, fortunately, there are those of us who do have answers, not
mm,
those of us who try to find ways to not acknowledge the answers. Let us face it, we do know the biomechanics of biological injury.
yeah,
We know
yeah,
what
yeah, yeah,
fractures an end plate. We know
yeah,
what fractures a pars. We know what protrudes a posterior disc. We know the behavior. We know the
mm,
flexion. We know the extension.
mm,
We know the loads. We know the frequency.
yeah, yeah,
All right.
yeah,
What's the problem with that? Oh, you
yeah,
can't see it on a scan. Yeah,
yeah,
and where's the evidence that there
yeah.
is any other mechanism? And there isn't evidence of any other
Mm-hmm.
mechanism. You know your
Yeah,
mechanisms. So do I.
Yep.
So
And accumulative injury, breakdown of the collagen matrix of the disc. It's no surprise that you then one day sneeze or cough, roll out of bed, and you get a disc prolapse.
no mystery at all. Their
Yeah.
approach is akin to the Bertrand Russell China teacup circling the sun. Just because you can't prove it's there means it might be there. No, the onus is actually on you to prove there's another mechanism.
Yeah.
Come
Yeah, I
forward
mean,
with
that's
another
right.
mechanism.
It's almost like, well, you could say to Greg and his supporters or proponents, if biomechanics don't matter, what does? What if you're saying that biomechanics are not important, then you've got what is important in preventing injury? What is important in performance? So they're not coming forward with an alternative, and we can see how epidemic the problem is.
It's quite amusing, really. All there is, I even look back to O'Sullivan's failures. It's the simple thing is they've missed certain factors that they didn't understand. And because they failed, they tell everybody that they knew as much as there is available, and that's it. Well, they didn't. Their failures are just simply their own personal failures.
Why do you think there is, like, we have to accept that some of these proponents of the anti-biomechanics message that we support, we have to accept that they do have quite a subscribership.
Well, so does
You know,
so do the people who follow Tolkien's Middle Earth and dress up on the weekends. There's communities. Doesn't mean they're all
yeah.
that rational.
Have you tried to reconcile where that support comes from?
Yeah, I think it's pretty quick. It's pretty much the same sort of thing that happens in every industry, and it's got your footy teams. People become part of a tribe. That's all it is, and then they defend the tribe to the death, regardless. And that's what it is. Now, I've always advocated that professionals should lose their religion. Stop being just this. Stop being just a physio. Stop being just a chiro. Open yourself up to understanding there's a world of science that you can understand. These people are committed to basically a tribe, and they'll fight to the death for their tribe. We should never waste our time trying to convert those people. It's a waste of time. We've simply got to help as many people as we possibly can, and we can. And it's the same path that, say, O'Sullivan actually tried to go down. He tried to assess. He said it. You need more specifics to apply specific interventions. And because he obviously ran out of the ability to do that, well, don't blame everybody else. That's your personal failure, Pete, not ours. We actually do lift. We actually understand how people move. Our lives are dedicated to movement. That's all we've ever done in our lives. I mean, I started as a kid in sport and played for state teams and national teams in different sports. Basically, 3 different sports I have national titles in outside of weight training. So, of course, I understood the importance of technique. These people don't seem to have ever had a depth of accomplishment in any endeavor that's physical and requires technique. I think that's where their failures come.
It's very disappointing and sad and serendipitously, like if Pete O'Sullivan and Greg Lehman had joined a powerlifting gym, they probably would have had a polar opposite approach, and the back pain. Some of these people who are prolific publishers in university positions and have influence on government policy, which currently certainly we don't as the college. I think we have to accept that at the moment. But if those people had learnt what was primarily important in lifting heavy things, the entire global situation of back pain could be quite different.
It could be quite different, but there are so many people out there. There's always going to have people who have oppositional views. They're graduating. Someone's graduating today who's going to grab that mantle. So realistically, the strength of what the college produces now is to give information for those people who really are looking for answers to become successful practitioners to help human beings, for people who want to give answers and the rational answers, the clinical answers. the ways to assess, to ways to give people solutions. That's really what we do. I mean, in your work, you often see the end product of the failures of conservative management.
Mm-hmm.
I mean,
Absolutely.
that's really where you go, isn't it? That's where they
Ye-
come to you.
Oh God,
In
yeah.
a
Well,
lot of
yeah.
them.
As a surgeon, you always get them at the end of the railway line. I'm the last port on the desk on the journey, really. And it's really hard because I sort of need to say, well, I know you've had pain for a very long time, but really your journey to recovery is only starting now, um, because this is the beginning of your implementation of effective rehabilitation. I know you've had all of the other stuff, but sadly, your therapists and allied health providers have not given you the vital tool to hit the nail on the head. They've kind of been banging around the side here, but the big dirty nail that's sticking up out of the floorboard has not been hit down, and hence you're still suffering. And we've got to start that journey now.
It's a very interesting thing. I mean, I'm going to obviously see a lot of patients who contact me basically as a last resort because everything else has failed.
Mm,
And they'll have had 10 years of fairly significant impeded life. And when I
mm,
start an assessment, I'll often say to them, has anyone ever done this to you? Anyone ever done this assessment? And I look at them and go, no one's ever done that. And you look at it and go, that's horrifying.
mm, 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 mm.
Professionals do not appear to understand how to assess a complete human being. So, of course, if you can't assess something specifically, you're not going to actually be able to apply a specific outcome to that. And if you don't apply a specific outcome, what are you doing? You're shotgunning. You may work. Well, and
Mm.
biological healing is going to guarantee some success in the short term, but never does that actually resolve recurrence. Recurrence is a guarantee unless you can understand the
Yeah.
basis of the original problem.
Yep. 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 Yep.
So now you're going to be doing a spinal fusion, and you can see that a person has some things that need to be assessed.
Mm-hmm.
You've got to send them to someone who can make the surgery a success. It's now up to the rehab to be a success for the person. So
Yeah.
have you got a few people there?
My job as a surgeon well, surgery is a purely structural intervention. But it's always emphasized that this is fixing up a downstream problem of a primary functional disease. So if I fix the downstream problem, you're not fixed holistically until we fix the primary upstream causation as to why your disc deteriorated. And that's when we recruit people that understand movement to sort of close the circle on the care. And we know that spinal fusion surgeries globally are reported to only have a 50% success rate, and that's very disappointing. And even as an industry, the surgeons go, "Oh, we're only succeeding in every second operation." That's abysmally low. That's
But what are
abysmally low.
those
But
what are those statistics based over what period of time? Because essentially, what would be the percentage of people who, after having fusion, a month later, would say that the outcome is excellent?
yeah,
It'll be
that's
a
right.
lot more than 50%.
That's right.
It's
Yep,
now
yep,
the surgery was in fact successful.
yeah. It was successful, and then the recurrence of pain, as you alluded to, is secondary to ongoing movement dysfunction that then drives adjacent segment nociception and inflammation, and then now you have the adjacent segment disease, which was created by the lack of attention to reversing the movement dysfunction.
That's it.
Um,
So
I,
realistically, these papers that are reporting 50% success of fusion,
yeah,
their actually conclusions are entirely erroneous. They're not
it,
evaluating the other variables that are included.
it's a misinterpretation of the observation and misinterpretation of the data. Um,
Mm.
because every surgeons will look at their work, they'll look at their post-op X-rays, their post-op CT scans, and say, "This is fantastic. I've done a great job." So, from a
Mm.
technical aspect, the success rate of spinal fusion surgery in the mind of the surgeon is, 95 to 98%. Yes, in 1 to 2% of cases, there can be technical misadventure, and
Of
that's
course.
a sad thing, but a reality of a high risk procedures. But in terms of the technical delivery of the surgery, it's actually got a very high success rate. But that delayed outcome of 50% is very disappointing, and I think we can improve that long-term statistic by having spinal surgeons as well understand movement dysfunction and the importance that that plays in the management of their surgical outcomes.
How do you think the spine surgeons as a group are motivated to do that? Because there's definitely the motivation to do good work.
I have tried to raise this with our Spine Society of Australia, and I think the general feeling is that as a surgeon, it's their job to do the surgery, but they will then shift that responsibility back to the rehab industry, and that would be fine if the rehab industry had the same perspective on the problem as the college does, as we do. But unfortunately, it's pot luck. Like if spine surgeon in Melbourne did a spinal fusion, then sent them to you, that patient would do well almost 100% of the time. Okay, because the surgery
100%.
goes well. That's right. But if they go to the local corner store Pilates studio, and focus on core strengthening, then we know that core strengthening doesn't mandate skillful movement. You can be a strong person moving poorly. And so that patient will unfortunately be victim to the 50% success rate, depending on whether they serendipitously slip back into good movement proficiency, which they probably won't, because if they didn't have good movement proficiency before the surgery, why would they suddenly just slip back into good movement proficiency after the surgery? Sometimes it happens because the surgery reduces the nociception and inflammation from the motion segment, and therefore a instantaneous reduction in pain can allow people to then start moving correctly. But that's a flip of the coin likelihood. Okay, and why not just maximize the odds for great outcomes every time?
Well, that requires that we have a cohort of professionals to hand the rehab work to.
Yeah. Yep.
Now that's going to be the next interesting outcome study then, is to look at the 1 to 2 to 5 year outcome rate of people who have gone through a specific group of movement professionals, and to see if their outcome rates are better.
Yep.
Of course, we know they're going to be.
I mean, that's the data that we could start to generate, and it would further compound our stance. I think.
Very much.
Have you heard of this? Have you heard of the Swedish lumbar spine study?
I've heard of many studies. Yes, I have.
Yeah. Well, the Swedish lumbar spine study, I think it won the article of the journal article of the year. They call it the Volvo Award, and it did show it did compare standard rehabilitation for back pain, usual care, in a multi-center, Swedish region, with spinal fusion. And of course, the short-term outcomes showed spinal fusion was superior to rehabilitation and usual care. But there was a follow-up article about five years later, and all of those people that had the initial very good outcomes from spinal fusion were now back in pain. So now you've got the people interpreting the data and going, well, spinal fusion is not worth the risks and costs. But they are not, again, they did not look at what happened to that cohort of patients that had spinal fusion and what happened to their movement proficiency after the surgery. So it's no surprise to me that the back pain cohort started getting pain again and adjacent segment disease related pain 5 years after the surgery.
What's really, really super strange is that we identify, because we've decreased the motion segment through fusion, we know 100% that there's going to be increases of motion at the adjacent segments. We know that 100%. Okay, so what is the rehab protocol that is addressing that? There isn't one. Why not? Because that's the obvious thing in the intervening years. We know those motion segments are going to move more. Okay, what are you doing about it? Well, there's the failure. And that's what us as movement professionals know how to do. We know how to teach people to get a greater capacity for life. We're not stopping them from doing everything. We're just giving them the greater capacity for movement in the times when it's not necessary to get that accumulative stresses upon those segments. We can control those things. It is the most intriguing thing to see, because biomechanics seriously matters. So it is straightforward, isn't it, really? It's just great. We can see the variable that is not being written about. And that's just so strange.
It's clear as crystal. When you understand the big picture, you can kind of, and you have that nice clinical model, and you can see where the failings are. You know where you have to do the work. You know where to patch up the missing links in the chain. And if you don't have that clinical model and that paradigm, I feel as though you just randomly, let's do a bit of acupuncture today. Let's do a little bit of dry needling. Let's do a little bit of, wheat packing or manual therapy, stretching, deep tissue release. And there's nothing wrong with that, but it's very random and it's not really closing the whole the loop to get that successful outcome. It's very random, unstructured, and the patient just feels like a pinball bouncing around. What should I do next?
As you've always said, pain is not a diagnosis. It's a symptom. Now, professionals, time for you to give me the diagnosis that may be producing that pain. You're going to have to search harder. You're going to have to explain yourselves. Of course we can, because we can actually assess a human being, find the biological, biomechanical trigger that the person says, yes, that is provocative. Okay, here's a change. How does that feel now? Not provocative. Good, and I can tell you why. That's our job. We can actually make significant intervention from day one, as we always do. I often point that out to patients. You probably only need 1 to 2 sessions with me, and I can send you off to another professional because I'm busy and I'm very expensive to see. But I can set the plan up, and I have professionals in my network who I entirely trust, who do the work, who are cheaper.
And that's what we want to do. We want to be able to have people in every region that are part of the college and that are members and understand our message inherently. I think they really have to understand lifting themselves if they're going to be training other people to move biomechanically well. So that surgeons in every part of this country, GPs, patients themselves, can just look up the website and say, where's a functional movement clinician near me? And then it just, because at the moment I feel as though we're just like a little island, we're just, people have to travel from interstate.
They travel from around the world.
Down. So I have people coming and they have to rent a hotel room for 2 weeks to do our movement therapy course.
Fantastic.
It's just sad that they have to do that, and they have to, put their life on hold to come to Brisbane, or because our course is not a 1-day course. It's generally a 2 to 8 week course, and even our 2-week course, we're condensing a lot of information that we would normally deliver over 8 weeks into 2 weeks, simply because of geography and keeping things practical for patients. But it's just insane that patients have to do that because they say, can't I do this up here in Cairns or Townsville? I'm sorry, I just don't know anyone up there who will deliver movement therapy reliably for you. And I always check, I always suss out because there may be someone who is on the ball and doing it. And I say, okay, I want you to tell me what happens when you go to see your local therapist. Tell me what happens after you say hello, after you swipe your credit card, after you say good morning. What do you do? And it's always, well, he comes or he or she comes and they assess me, they see me bending this way, bending that way, and then they lay me down on a couch. And then I lift my
Like it,
knees up, I roll this way, I tuck this way, and then I turn over on my back, and he releases my tightness. And I say, oh, okay.
and
And then I
then
just ask them, I just say, bend over, and there's a cup of water on the coffee table in my office. Just bend over and pick that cup of water up. And of course, they deactivate their posterior chain. They lose that active position. They hip centric. They lumbar centric rotate. Minimal hip centric rotation. They load their knees, which of course is breaching all of the defined rules of movement proficiency. So I can say, well, it's very clear to me that even though you've been to your therapist 20 times in the last year, you have not received effective movement therapy. So yes, you
it's
do.
so amazing. Well, because we actually have so many clear demonstrations in research on the area that people with lower back issues move differently to those who don't.
Yep.
Now, we know they move differently. So why isn't that being addressed?
Yeah. We need to break
I've yet
that
to
cycle.
I've yet to see a study that said otherwise. So that's a weird thing about it. They move differently, but it's almost like they say, yeah, but we don't know how to change it. No, yeah, you do. There
Yeah.
are definite differences. And we
Yeah.
understand once a person's been injured that if we look at the Punjabi model of neutral zone theory, we understand the deficiency in one area can be made up for an increase of work by other areas, motor control, muscular control. Straightforward, it's always been that way. We use that in ACL rehabs now. It's the same thing. You have an insufficiency, good, we're going to increase your active sufficiency. And you've seen in the multifidus muscle atrophy, the lack of segmental control. And it's a hallmark of
100%.
people with lumbar spine problems.
It's just it's so glaringly obvious. So tell me, so going back to the ACL, so we can extrapolate to another joint in the body.
Yeah,
So if someone has knee instability,
that's right. That
how do
ACL's
you
gone.
how do you how do you how do you fix that up? Because we know that stability has three main components, the neural control, the passive elements, and the active elements. So with an unstable knee, what do you try to do to reacquire stability of the knee?
Well, we actually work on obviously one thing, which is strength. We must remember, what is strength? Strength is a skill. So it's the interplay of the muscular contraction with a movement pattern that is neurological.
That coordination.
And we are protecting then the passive structure from having to take up the slack for that insufficiency because it's no longer there. Yep. Now, we actually make people better than they were prior to the injury.
Yep.
Because you don't have the passive structure supplying its part of the equation.
Yep.
There are so many world-class athletes in different sports who do not have ACLs in their knees. It's almost getting to the point of you would spend a long time counting how many there are at Olympic level, at professional sport level now, who have not had ACL surgery for reattachment and are back into their sports with great management. And that's what our best professionals are doing. They're doing exactly that. They are rehabilitating people to make up for that passive insufficiency. And that means those people are not having 12 months off their endeavors. They're back in there within a couple of months. I think we have one Olympian basketballer who's hamstring strength is almost unmeasurably strong who doesn't have ACLs.
So let's
Here's
put that in. Let's put that into perspective then. So sometimes the knee surgeon will deliver a passive structural intervention and try to repair the ACL, and that's, again, we're trying to top up the passive elements of stability. You most likely will still need to do some active improvements with the strengthening of the hammies and quads, and of course upskill the neural control and skill of movement. So there's your three elements at play, which restores stability to the knee. And you've just said that even some athletes or people who have not had the ACL repair, if you maximize out the strength element or the active elements and maximize out the control and skill elements, you can still counteract the passive element, which is torn, and still have stability.
And we can do that with backs.
And that's the same principle but yet when it comes to the back, like there's probably very little conjecture when it comes to the knee, right? There's probably very little conjecture. Everyone kind of has the same paradigm.
Well, what happened in the back was everyone
when we go to the back, it's like we just throw all those principles out the window.
Well, we didn't at one point, which is amusing. I think we could go back to just around about the year 2000-ish. And all the hope was, we understand multifidus is atrophied. We're going to pull our transverse abdominis in because it co-contracts the multifidus. Welcome to the immediate failure. The recognition was that there's atrophy of the multifidus, lack of segmental control. But the intervention they used was incorrect. And because that failed, they deemed that was all there was to it.
Right.
I look at some of O'Sullivan's work there.
That intervention had merit, but it ignored the other element of stability, which was neural control and the skill of movement. Because we know there's three elements that are important. They just focused on one thing. They just focused on the active strength element. They ignored the most important thing, which was the neural functional control element. And hence they still did not create enough stability to prevent pain and disability.
Now, because there's so many factors there.
They threw the baby out with the bathwater.
They did. Now, just because they couldn't explain it meant they abandoned it. They knew that there was a lack of motion segment control.
Yeah.
But their intervention was a failure. It doesn't mean the approach is a failure. It just means you just failed in what you just tried. Get over it. Find a better way. Now, the better way may have more variables than you currently know how to measure. Well, too bad. At least what's going to happen is you're going to make people better, and you will take time to learn how to evaluate those variables. You may not have the tools today to evaluate those variables, but you know the overall system and the theory is correct. And that's where the people in the academia who have calluses on their fingernails, on their fingers, and not calluses on their palms, they don't understand the amount of variables that we are dealing with. But that's what we as professionals do. The highlights are there. So it's that failure of the academics to accept that if you can't measure something, it doesn't mean that you abandon it. It means there's a new pathway you've got to learn to examine.
Yeah.
And we know it. We can put it in the framework. Now, the next thing is we can continue to make this better, and we continue to make our patients better. Now, the academics, if they wish, they can start to tease out the variables and start to see how they fit together. But in the meantime, you've got a decade or two of work to do there. And I'm not going to abandon patients for a couple of decades when I can make a 50% success rate turn into a 99% success rate and help so many people worldwide. I'm happy for everything, the evaluations and the measurements to catch up, but the outcomes we can easily prove are miles better.
Yeah. Okay. Well, I think that's a pretty good coverage of management. We got a couple of minutes left. Maybe next week we'll talk about I was ready to talk a little bit about the misinformation and the myths surrounding back pain, but we started moving down the management paradigm or the management discussion.
Yeah.
We've got a few minutes left there, Andrew, on the old Zoom. Any
I've got a
last
thought there
minute
too.
things? Any last
Yeah.
minute points about management that you want to say?
Well, I was contacted only yesterday by one of the major conferences of physical therapy and rehabilitation, one of the world congresses that I think is the 5th World Congress. It's going to be in Bangkok in March next year. And they've asked if I'd present at that one. Now, you never know. If you're available somewhere in March there for
I'll be
a
there
visit to Bangkok, we can go ahead and we can present this to the rehabilitation community at the World Congress.
World Congress sounds very prestigious.
Oh, I did mention them to you, so you to them.
Would do you think your friend Mr. Lehman would be in the crowd?
No, actually, I don't think they're dribbling on about pain, construction, and nothing to do with skateboarding or bouncing on trampolines. So perhaps he won't be there. But if he is, I hope he attends. We can point out his failures.
Well, actually, we've got a couple of minutes left, but there was a thing that we started talking about. He started to agree with you when you talked about all of your elite athletes and how you resolve their pain symptoms by retraining biomechanical proficiency. And then he said, I agree with you when it comes to performance athletes, but I disagree with you when it comes to back pain injury for the everyday person. Now, I was thinking to myself, what about the context of an accountant who's not very fit and his performance is just going to work and doing a bit of gardening? Isn't that still performance? So
I'm sure Oscar Wilde would say life is a performance.
Life is a performance. So he's got a complete disconnect between the relativity of what performance means. So just because your patients are performing on the world stage in athletic arenas, but what about my patients who are performing at work, in the kitchen, in the lounge room, in the garden? It's still a performance. And so there's no difference between the fundamental principle of delivery of care for that person, just like you would deliver care to an athlete. It's still performance related. I was hoping Andrew just smash him on that point, and he kind of got distracted. But
he got lost.
It just made.
Well, let's face it. If picking up your grandkids was an Olympic sport, then we would have coaches to show you how to do it.
That's right. Exactly right.
Performance is life.
Performance is life. I coined the term a while ago, the sport of life. Be good at it.
It is.
Yeah. The sport of life. Be good at it.
We're both heading into we're doing the sport of work right now, and we'll be into the sport of gym real soon.
You betcha.
That'll be our day's work. You off to train today?
Okay, Andrew. We got a countdown, and
we do.
We'll catch up in a short while, maybe next week even, and let's talk about the myths and misinformation, because I made a few notes here about the myths and misinformation.
Well,
I made those notes just from one day in clinic, seeing 15 patients, and those 15 patients I just wrote them down as the patients came through. Myth number 1, myth number 2, and I got a whole list here.
Right.
Let's talk about that.
I'm looking forward to next week, same time. We shall do that, and I'll flick you through the invite to the World Congress.
Okay, sounds great, mate.
Enjoy the action. What another huge day.
Have a great day. Bye now.